Thank you for attending this webinar sponsored by NAMI Wisconsin, the National Alliance on Mental Illness. NAMI is the nation's largest grassroots mental health organization providing advocacy, education, support, and public awareness. NAMI Wisconsin is a state organization of NAMI, and our mission is to improve the quality of life of people affected by mental illness and to promote recovery. Today's webinar is funded by the Wisconsin Department of Health Services. NAMI Wisconsin has been partnering with consumers, service providers, and law enforcement for a long time, and we recognize the importance that mental illness crisis response is the top priority. In this webinar, we'll hear from 4 presenters who will discuss mental health crisis response models that have been successful in rural, mid-sized cities in Colorado and the CART program in Milwaukee, Wisconsin. Our presenters are Laura Cinconi, Carrie Bolter, Erin Milliken, and Lauren Hubbard. We'd like to see what sectors of mental health support are represented in the attendees. If you could take a moment to fill out this poll, then we can see who is in attendance. And we're just waiting for the results. If you could just take another moment to do that, then we'll share the results with everyone. All right, do we have results that we can share? So it looks like we have a pretty good split group in terms of people attending a first NAMI event. Thank you for returning. And a pretty broad sector of participants from different sectors of representation, mental health professionals, people living with mental illness. We have a pretty broad range in terms of rural area, suburban area, and urban areas is pretty split right along equal parts. And most people seem to have a sense of what their community resources are for mental health and mental illness response. And most of you know about NAMI Wisconsin, which is wonderful. So let's continue on with our presentation. We will be hearing from our presenters, and at the end of the presentation is when we will have questions and answers. So during the question and answer time, you can just put questions on the Q&A part of the taskbar, and then we will be collecting the questions as we go along. And then at the end, we'll have time for question and answer from each of the presenters. And just to let you know, this webinar is being recorded and will be available on the NAMI Wisconsin website. Thank you for your time, and we'll begin.
Hi everyone, my name is Laura Cinconi. I coordinate the Douglas County Mental Health Initiative in Douglas County, Colorado. In Douglas County, our co-responder program, the Community Response Teams, which you'll hear me referred to as the CRTs, is a program of our mental health initiative, a group of about 35 to 40 organizational partners from the county, school district, first responder agencies, public health, justice system, on and on, who all work together to strengthen the community-based mental health delivery system here. It's what makes us unique in Douglas County, having all of these partners supporting our CRTs. Next slide, please. Are we able to advance to the next slide?
We're having some technical difficulties, Laura. Thanks for bearing with us.
Gotcha, thank you. Great, thank you. Okay, so today I won't be speaking too much about the program structure in Douglas County. You'll learn from others that they can look very different depending on community need. But my focus will be on some of our key data and outcomes as well as budgeting. Next slide, please. To set the stage, Douglas County is located at the south end of the Denver metro area with urban pockets in the northern portion of the county closer to Denver and also centrally. About 90% of our population is living in these suburban areas. The south, west, and east portions of the county are rural. And we've seen quite a bit of rapid growth here in Douglas County over the past 30 years. In Castle Rock, pictured on the left, there were maybe 1 or 2 stoplights here in the 1980s. And as you can see now, it's a bustling suburban community. Today, Douglas County has a population of about 370,000. Next slide, please. Early in the mental health initiative's existence, partners identified a need for an alternative response to crisis behavioral health calls that came through the 911 system and a solution to the revolving door that first responders found themselves in, where a 911 call was made. Most often someone was taken to the emergency department, discharged to the community, and this cycle would repeat. So hence the CRT was born. We started with a pilot in 2017 with Castle Rock Police Department, the Douglas County Sheriff's Office, and the Castle Rock Fire and Rescue. After the pilot, we presented our preliminary data to the county commissioners, who after seeing our results in such a short time frame and hearing partner testimony, knew that they wanted to continue to support the program. And since then, our CRTs have expanded to include Parker Police Department, South Metro Fire and Rescue, and the school district, who's a key partner in our youth CRT program. In our county, fire EMS partners do not ride in the vehicles. In some cases, in other communities, they do. But our CRTs dispatch a specialized response with a specific vehicle and specific paramedicine professionals who provide medical clearance. And this is a key step that allows us to bypass the emergency department in favor of direct placement to mental health settings as needed. And luckily, our smaller fire departments in the rural areas of the county have agreed to allow this specialized response in their jurisdictions. Next slide, please. We measure 4 primary goals, essentially diversion from default settings like emergency departments in the criminal justice system, which really aren't equipped to provide the level or type of care needed in these situations. There are, of course, times where those settings are most appropriate. And if that's the case, our CRTs can facilitate that and work with partners in the community to make that happen. But our core goal is to divert those cases that do not need care from an ED or emergency department setting, or really don't need to be charged and jailed. And that is in favor of, again, diverting to other care settings. And in many cases, we are able to safety plan and allow individuals to remain in place with follow-up from our case managers. On the right, we have a graphic of our team's coverage across the county. All CRT officers are deputized, meaning that they can cross jurisdictional lines. This allows the teams to provide backup to each other. And Lone Tree Police Department, which is the area of the county that isn't filled in by a color, They partner with the CRT program as needed for response on active 911 calls and for follow-up on referrals, given that they just don't have the same volume or need for a program like this. But with this partnership, we are able to effectively cover the entire county. Next slide, please. Okay, so pivoting to data. Data has always been essential for us. Prior to my role as the coordinator, I was the evaluator and data analyst for the CRT program in Douglas. I'm very familiar with this portion of the program. It was a part of our planning phase before CRT launched. We used data to monitor community trends. And now, especially with COVID, CRT data has been a window into community need. We use it to schedule teams for effective shifts with the most reach, and of course, to evaluate for the purposes of continuous quality improvement. It'll come to no surprise to many of you that data is important for stakeholders, especially for first responders who make significant in-kind donations, and the county and states who fund our teams. Data is also about telling the story. So I'm not just talking about numbers. We found that using testimonials from our partners, using de-identified client stories, helps expand our understanding of what these teams do, which is very often far beyond just showing up at someone's home and doing a crisis assessment. Next slide, please. This is an example of data that we regularly report out. In this case, cumulative data from our pilot period through the end of last year. I've pulled out a couple of points that align with our goals. 586 emergency department diversions in this time frame, 208 jail diversions, and the individuals served by case management. Cost avoidance is also a really big part of what we try to present every time we do a report. And I'll talk about that a little bit later. Next slide, please. Here we have similar data points on the slide prior, but more recent through the first about 8 months of this year. And I'll draw attention to a few points here that we track both fire and emergency medical system vehicle and personnel released, as well as patrol officers relieved, to inform our goal of reducing the burden on first responder systems. Not pictured here, but we also track patrol unit time on scene with CRT units versus without. And we found that the CRTs can provide comprehensive de-escalation, assessment, and secure disposition within about an hour. Next slide, please. In addition to monitoring these data outcomes, we look at a lot of other data, but I wanted to pick something that we found really impactful. So this is an example of an organizational level outcome, a decrease in 72-hour mental health holds, or what we call in Colorado M1s, since the start of the CRTs. So you can see that there was a clear and steady increase in mental health holds since 2011, and following the CRT pilot and program expansion, we've seen a decrease. Next slide, please. And when we took into account population growth, which is represented by the blue bars in the graph, we still saw a reduction in M1s. And after talking about this with the sheriff's office, no other programs had been implemented or policies changed that would have accounted for the reduction after years of climb and an increase in population. Now, it's always difficult to say definitively whether your program has had that particular impact, but this was especially intriguing for us and something that we keep an eye on. Next slide, please. Cost avoidance, hugely important indicator and factor for us in Douglas County. It helps us understand what impacts we have on first responder, healthcare, and criminal justice systems. In our formula, we look at tangible items, the emergency department, jail, and fire EMS cost avoidance. So the points on the screen summarize what we consider in our formula. We're working on including other aspects of cost avoidance facilitated by those CRT programs. For example, with jail diversion, we would like to include the avoided cost of legal defense or bond, for example. We don't yet have a formula or way of capturing those intangible aspects of avoiding jail or the emergency department. In other words, those social and emotional cost savings. But we really do recognize how valid and important the human experience is in this process. And, for example, avoiding the emergency department or an unnecessary mental health hold may mean avoiding an unaffordable medical bill or a day or two of missed work, emotional or familial strain. Next slide, please. So in our first year, we saw around 1.7 million in cost avoidance. In 2019, 1.7 million, nearing 1.8, and cumulatively from May 2017 to December 2019, nearly 5 million in tangible cost avoidance. Next slide, please. So our budget. In Douglas County, 3 out of 4 of our CRTs are funded by the county's general fund, meaning 6 out of our 8 clinical staff, our clinicians and case managers, are funded on an ongoing basis by the county. 1 out of 4 of our teams is grant funded through the State Office of Behavioral Health. We also use this grant funding for a variety of operational costs, most significantly our integrated and mobile case management system, which we use to track data, network, and collaborate with providers and community partners and maintain our case management program. Something that makes this a little bit different in Douglas County is that we contract with a private psychologist office for our clinical staff, and many programs around the state work with the community mental health centers. Next slide, please. For us, it's worked really well to have dedicated officers on the teams, meaning that the officers interview for the position, they have crisis intervention training, and they really want to be doing this every single day. Officers are paired with a clinician and they ride together 40 hours a week, so these teams are dedicated to the response. And as you can see from the example below the last point, our law enforcement partners do make significant in-kind contributions to the CRT. I'll round out my portion of the presentation by saying that we do feel lucky to have ongoing support from the county commissioners in Douglas County, and therefore, that ongoing funding. A lot of programs in Colorado right now are grant reliant. We have members of our mental health initiative and CRT leadership who've had the opportunity to participate on a governor's task force for behavioral health over the last year. And they've advocated to both recognize co-responder programs as part of the continuum in the state crisis system and find ways to ensure that programs do not have to rely on grants in the future, that they won't go away if grant funding goes away. So certainly something for Wisconsin to consider as you all think about expansion. And I will end there. Thank you so much.
Good afternoon. I'm Carrie Bolter. I'm with the El Paso County Sheriff's Office, and I'm the Behavioral Health Programs Manager, and I'm the supervisor of our co-responder team. Next slide, please. Our unit is called the Behavioral Health Connect unit, and we term it BHCON. And we are affectionately called by some of our patrol deputies and dispatch as Bacon, but we like that. It's fun. And our unit is made up of, next slide, Pete, please. We have a dedicated deputy from our sheriff's office that is CIT trained, that is paired with a UC Health Memorial clinician that's contracted to us. So our local hospital system contracts us the clinician who is licensed, and the clinician, similar to Douglas County, rides with the deputy for 40 hours a week and responds to mental health related calls. Our goals are similar to Douglas County CRT in that we aim to divert individuals from jail And when our deputy has discretion on lower level misdemeanor type crimes, not make arrests and instead connect them to behavioral health services that might intervene in their behavior. And we also try to divert from our emergency room by doing direct MITs into our local psych hospitals. We also are trying to connect individuals to sustainable community services that perhaps will prevent future crises. And we have a case manager on our team that I'll tell you about and what she does. And then we also, one of our main goals too for our office is to release our patrol deputies back into service. So our team will stay on scene on a mental health related call and release all of our other patrol deputies to be able to respond to more high risk or in-process crimes. Next slide, please. So my presentation is really going to be more around the operational and day-to-day aspects of our team, so you can get a look at how we function on just a daily basis. And so our composition of our team right now is the Behavioral Health Programs Manager. That's me. I'm the supervisor of the unit. We have a dedicated sergeant that our sheriff's office has given us who oversees the daily operations of our unit and any law enforcement related needs. We have 2 dedicated deputies to our team at this point, and they're both CIT trained. We have 2 licensed clinicians that come to us from UC Health. And then we also have a full-time case manager that the hospital contracts to us. And that case manager's position has been integral. We just got her this year, and it has really increased the amount of follow-up that we're able to do with the clients that our unit see on scene, and then she can help connect them to resources where our unit maybe doesn't have time to stay on scene because they have to respond to other calls. Our case manager is able then to get a hold of the individual after the crisis, find out what their needs are, connect them to appropriate resources in the community. We've also been able to set up a program with our office that allows our patrol deputies to send referrals directly to our case manager. So say our patrol deputies respond to a mental health related call, they see that this individual might benefit from further services, and they send that referral over to our team, and our case manager will get a hold of that person. Next slide, please. Currently, we are an all-woman team. I wanted this slide in here to show the uniforms of our team because all of our co-responder teams in the state have different uniforms, and wanted to talk a little bit about why we chose what we chose for our uniform. And so our law enforcement wears their typical law enforcement attire. They have their vests, their guns, everything they would need. Part of that is because our unit also serves as a patrol function. And so if our unit is not responding to mental health related calls, our patrol deputies are still able to help and take calls for service or provide cover for calls for service so that we're still an asset to our patrol unit. Now our clinicians and then our case manager, in this picture, you'll also see our behavioral health director from the hospital who is also a part of our team. Our clinicians wear, you can see just a polo, it says behavioral health on it. It does not say sheriff's office. And then they do have a vest. So we do put our clinicians in a ballistic vest because they are riding in the car with our deputies, and there are times that they may be on a scene that could potentially get violent or unsafe, and we want them to be protected because they are in the front seat of that law enforcement vehicle. That vehicle is an unmarked Tahoe. We use that because we are trying to be less threatening to the individuals that we are trying to serve. But it is still a law enforcement vehicle, and like I said, our patrol, our deputies still function in a patrol manner when they are able. Next slide, please. Currently, our schedule is overlapping for our 2 units. So one of our units works Monday through Thursday, 10 to 8 p.m. because that is generally the highest call volume for our office for mental health related calls. And then that second team overlaps them Tuesday through Friday. And that way we're able to cover that Tuesday, Wednesday, Thursday period that does have the higher volume of mental health related calls. Beacon 3, that is our sergeant and myself, that when we're able, we get out there as a 3rd team so that we can assist in providing coverage because our office receives between 375 and 400 mental health related calls a month. And our 2 teams are only able to respond to about 100 of those. And so when the sergeant and I are able to, we get out there and provide a third response. And then our case manager works normal Monday through Friday hours. And so what she'll do is Monday morning, she takes any referrals from the weekend and follows up with those individuals. And she does that throughout her week then. Next slide, please. So we cover unincorporated El Paso County. You're going to hear from Colorado Springs CRT a little bit later in this presentation, and they cover the city. So our area is about 2,100 square miles. Our population for the entire county is around 720,000 people. We are asked at times to come into our local jurisdictions. So you see Manitou, Monument, Fountain, Palmer Lake, Green Mountain Falls, and Calhan. They have their own police departments, but they will request the BHCON unit to come in and help respond to mental health related calls. We also at times work with Colorado Springs CRT, and they have come into our jurisdiction when we've asked them, and they have asked us to come in and help out, and we do that as well. Next slide, please. How we generally receive our calls for service. Our deputy is always scanning our MDC, looking at all of the active calls and reading the call screens, looking for what appears to be mental health related information. So they may look at calls such as harassment, disturbances, etc., and they're looking for information related to that the call taker is taking, that the individual either being called about or calling in is having some sort of mental health crisis. There are other times that mental health related calls are more obvious. And so like a suicidal check the welfare, our dispatch center will then dispatch our team directly to that call. There are other times that our deputies or fire medical services are on a scene and they realize it's mental health related, and they will contact our unit and ask our unit to respond to assist. Like I said earlier, we get requests from other jurisdictions. They may be on a call. They say, wow, this person needs some mental health services. It would really benefit for you guys to come down. And if we're available, we do. And then, like I said, with our case manager, we do take referrals after the crisis. And some of those do require an in-person response. And so our BHCON units will actually go if our case manager requests them to actually go see the person in person. Next slide, please. These are the typical types of calls that our team takes. Obviously, the suicidal check the welfare and check the welfares that have a mental health related component to them. Suicide attempt. We have responded to completed suicide calls when we know that there are other members of family or friends on scene, because we try to provide assistance to them. Disturbances, safe to tell. So safe to tell here is, obviously mostly comes from our school system and individuals reporting about teenagers or younger children. Suspicious incidents, domestic violence. And then I have on here the request from city CRT, because if they ask us to come in for some reason, we do try to make that happen. Next slide, please. So what to expect if we respond. So our deputy is going to get out of the car first, and that is for safety. So our deputy will respond to the scene first, develop initial rapport, maybe de-escalate the individual if needed, make sure that the scene is safe. And then our deputy will then radio our clinician to come out of the car. And so at that point, our clinician does come to the scene. Clinician generally will contact any third party. So for example, if it's a mother calling about her son, clinician will try to talk to the mother first and then go meet the client. Our clinician will conduct our mental health assessment and uses the Columbia Severity Suicide Rating Scale to determine whether we're going to need to take this person on a mental health hold. Our clinician will then provide resources to any party on the scene that may benefit. And then our clinician is the one that makes the decision about whether we are going to do a mental health hold, if we're going to take somebody to a walk-in center, or if we're able to allow that person to stay in their home and we can safety plan with them. And then it is that clinician that makes that referral up to the case manager on our team. And then if our case manager gets a referral from either our team or their patrol deputy, our case manager will do a little bit of research before she contacts the clients and looks at their call volume for our office, how many times we've responded as a unit, how many times our other patrol deputies have responded. She contacts the client and completes a needs assessment with the client. And then she researches some available options in our community, and she will get back to that client and either offer those resources to the client or offer to make referrals to agencies on behalf of the client. Next slide, please. And as Laura said, data is very important for our stakeholders. And so this is our data from our fiscal year of July 1st of last year to June 31st of this year. Our office received over 3,000 mental health related calls, and our unit was able to take 906 of those calls and referrals from other deputies. Generally, we're responding to check the welfare calls. That's over 62% of the calls we take. And almost half of those calls end in treat in place. And for us, that disposition means that we're able to leave that person in their home and safely provide them resources and maybe safety planning if it's appropriate. About 16% of the time we are removing somebody from their home and we are taking them on a mental health hold. Our arrest rate is consistently between 1% and 2%. Mostly the arrests are because the individual has a felony warrant that our deputy does not have discretion on. And then our general ED diversion rate for last year was 89%. And part of the diversion rate for us, it was in the 90s, but when COVID hit, there was a lot of other expectations that our psych hospitals had for us and to be able to direct admit someone. And so we did end up having to take a lot more people to the emergency room because of medical clearance issues. With the inclusion of our case manager, we were able to attempt 758 follow-ups with individuals that our units had seen or patrol deputies had seen. And then we released 432 of our patrol deputies back into service by being able to stay on scene and manage that mental health call safely and allowing them to get back into duty. And so that is the end of the El Paso County Sheriff's Office presentation.
Hi, good morning. Can everyone hear me okay? I guess it might be afternoon where you're at. My name is Erin Milliken. I am the Director of Crisis and Acute Services at Aspen Point, which is a community mental health. And it looks like I showed my video. I'm not sure if that is seen. Okay, so there we go. So I am the director of a community mental health center, and I would like to talk a little bit, if you could please go to the next slide, about our community response team, or CRT, about the innovations in mobile mental and behavioral health response, or as we like to say, when a paramedic, a cop, and a therapist jump into a minivan, what happens, what goes on? And so what I will be taking you through is the startup process, how we defined the problem, how we came to the type of interventions that we landed on, what the results have been, what our data shows, and also some lessons learned, because we have learned quite a few things. If you could please hit to the next slide. Thank you so very much. So the first things that we had to do is, as the other presentations have outlined, is define the problem and what was it that we were facing. And way back in 2012, we had a community summit where we were really identifying that our emergency response system was misaligned. It was misaligned both for the providers, first responders, the police, as well as for the emergency departments. It often displayed or bared the burden of this care, of this misalignment. 50% of medical 911 response calls were for non-urgent situations, and approximately 77% of those called had an underlying mental health issue or concern. And while this would often take up large amounts of the deputies' time, the deputies were not trained or skilled in counseling for the mental health services. And this also resulted in an unrelenting cycle, which we would call our loyal customers, people that were continuously coming through the 911 system and were not receiving the care that they needed. Next slide, please. So once we had defined the problem and we figured out we all played a different part in as agencies of bearing this burden, but also not seeing the solutions we wanted. So we came up with this crazy idea that we were going to join forces, and we were going to join forces in our shared expertise to begin to deliver the right level of care at the right time to the right individuals. And we had tons of questions because this was pretty much, this is a lot of different perspectives to be faced and to be in one van together. And we really wondered, how can we deploy this team as a unified team? Will we see the results what we want? How do we spare this personnel? Budgets are tight, staff resources are tight. How can this help us? Is there a mutual benefit? And then finally, how do we come to a shared decision-making or agreement? These are three individuals, the police, the paramedic, and the therapist, that are used to owning the scene and coming up with the course of action that should be taken. So how do we combine all that to make sure that we're coming to the right disposition? Next slide, please. So as we were working through all these questions, we came up with this decision that we were going to launch the community response team. And the idea is that we would have the three separate personnel, the fire department, the police department, and the therapist, that would ride together in a nondescript van responding to low 911 mental health related calls, as well as calls from the Colorado Crisis Line. So this team officially launched December 1st, 2014, with a whole lot of nerves and excitement behind it. Next slide, please. We had a lot of ideas of what we did want to happen and what our goals were. And from first identifying the goals, we could then shape what the response would look like. Our primary goal is we wanted to provide the community with specialized first responder and mental health triage unit that allowed for a safe environment, that provided the correct level of care at the correct location, which would reduce reliance on the emergency response system and emergency departments. We wanted to reduce criminal involvement or recidivism due to mental health issues. And we wanted to treat the needs of the individuals at the lowest level of care and link them to resources to prevent the unrelenting crisis that many were experiencing. Next slide. Once we had the goals figured out, we then had to figure out, what does each person's lane looks like? What is each person responsible for? What is each role? The police officer obviously are responsible for the scene safety. They are all CIT trained. They are also, all officers are dedicated to this unit. So this is their full-time job that they have chosen to be a part of this specialty unit. They are always the first to approach. In the beginning, there would be so much excitement that everyone wants to go at the same time. So that was a learning piece of there's an order to things and how things go. We have a medical provider provided by the Colorado Springs Fire Department that is responsible for triaging any medical needs. Sometimes we are going on calls where someone has inflicted harm upon themselves, and so we're making sure that they don't need further intervention. They are also able to provide a medical screening for our direct placements so that we can bypass the emergency department. So someone can go from their home or where the location of crisis is direct to the level of care they need without unnecessary stops. And then we have our licensed mental health professional who is responsible for completing the clinical assessment. This includes the Columbia Suicide Severity Rating Scale, who's coordinating with the supports, who's the reporting party, who are some collateral, what are some additional information that we can give. The hope is that we're able to de-escalate, skill build, and appropriately safety plan at the location of crisis. This isn't always possible, but that's what we're hoping for. If needed, if that is not possible, we're then looking at, are we transporting to the walk-in center, which is a 24/7 service? Are we transporting to an inpatient level of care? Or have they fallen outside our medical protocol, either in medical symptoms or in behaviors that we need to look at emergency department? Another important piece of this is they provide the follow-up connections. So For fiscal year 20, 93% of the clients that were run on by CRT received a follow-up call within 48 hours of having that service delivered to check in on their well-being, to see how they're doing, and also connecting them with a case manager or ongoing services. For fiscal year 20, 75% of the individuals that we ran on had a follow-up and attended the follow-up appointment within 30 days. So that is a huge piece in preventing further crises from occurring. Next slide, please. So we launched our first unit in December 2014. Within the first 7 months, we had responded to 893 incidents. So there was a ton of excitement with this. Police were actually the agency to initiate wanting the second unit, which was such a change from the beginning when they were very reluctant to join us because of concern about how this left patrol with one less body. But as they saw the force multiplier, which I will show, and how it freed up other officers, they were clamoring for this second unit. So we were able to deploy that on July 2015. This allowed for us for having 7-day coverage. Once we had the 7 days established, we then have started looking for what is the swing shift, what are our later shift coverage needs. So in September in 2018, we deployed our CRT3 unit, which runs from 2P to 12A, allowing additional coverage. And hopefully in October, we're launching our 4th unit to allow 7 days a week of swing shift coverage. Next shift. This is the approximate of how we deploy versus how hours were decided upon was based on the level of mental health 911 calls, what were the highest call volumes. And here it breaks down where we received the most calls from. The highest amount is received by the deputy or by the officers attaching themselves to the 911 system for calls that seem to be mental health related. Additionally, there are unit-to-unit calls when an officer arrives on scene, feels that this could be better served by the CRT unit. And we also do receive calls from the crisis hotline. Next slide, please. So this is just an outline of how we go through to determine our disposition of patients. So how do we decide what the client needs and where they end up? Attached here, you will see our facility medical screening protocol. This is something we have worked with on the inpatient facilities within our community to allow for direct care. This is something that we have all agreed upon, that if someone falls within these levels, we can bypass the emergency department. Something the paramedics are able to do is the ISTAT labs. So they are able to do that on the scene. That was something that was initially done pretty frequently. Since as the teams have evolved and there's been increased comfort with their decision making, a lot of times the facilities are not requesting the labs. So the part that goes into this disposition is the clinical assessment of the clinician, the medical screening, and also kind of the team gets together and huddles, and based on these results, the clinician is determining what that final disposition is for their mental health needs. Next slide, please. An important piece is, as many have mentioned, the stakeholders. When we first started back in 2014, we initiated a monthly meeting of the primary stakeholders in our community. This included the medical hospitals, the inpatient facilities, our 3 main entities, and our detox as well. And this was called the Behavioral Health Control Committee, where it has shared governance over CRT. And we would meet on a monthly basis to discuss, are there any blips in the process? Were there any concerns? What is our data looking like? Are there any problems that we need to solve, and what our successes were, which helped define and drive as we launch further teams and really tweak to make sure we were meeting everybody's needs. Next slide, please. something that was early on was identified is the partnership and shared benefits that continue to enable this deployment. There was a breakdown of the number of site calls that we're seeing per year by each agency. Something to highlight is historically of these calls, 98% were being sent to the emergency department. Next slide, please. I did this from 2015 to 2020, just a highlight of the units released. This is broken down into the number of CSFD units, the number of police units, and then the combined units. Since inception, there has been 9,568,000 police units released. They tend to see the majority of the units. Fire department often will sees a little bit less for that. And then it also highlights the combined, which has been about 1,600 since we began, which obviously turns into huge benefits when these units are able to respond to additional and other calls that are not mental health related. Next slide, please. And so this highlights the disposition of CRT services since we began in 2015. The largest amount is are treated in place, that we're able to mitigate the crisis, figure out what they need at that location, and move on. The next piece was that the number of clients that were transported to our 24/7 walk-in center. A little bit lower than that was the direct admission. So these were individuals that were needing to be placed on a mental health hold and were directly admitted to an inpatient facility. Our emergency department, we had reduced that from about 98%, and it's still right under 20% of the individuals that we need to transport to the emergency department, and that can vary by year. And this can be either due to medical symptoms or, again, sometimes behavioral, extremely aggressive, extremely psychotic, that may need that extra intervention. Way down in the bottom, you can see the arrested, the criminal charges that were diverted, or I'm sorry, the criminal charges that needed to take place. And that is extremely low. It is under 1%. So for the rest of the individuals that we were called on, there were no criminal charges pressed. Next slide, please. So some of the challenges and barriers that we ran into, and there was a few of them. The primary issue or struggle that we had was, how do we integrate 3 different disciplines into a unified decision-making body? How do we manage personalities, very strong personalities? And I don't know if you sat in a van for 40 hours, but it is tough with 3 different people. And I'm not even talking about when you guys are deciding when bathroom breaks are or where lunch is going to be. So there was some personality management pieces to that. Another piece we had to be very intentional about was maximizing role expertise. There can be a tendency for people to shift outside of their lane. And so really what became our motto for a while was stay in your lane, where police would kind of drift into the clinician role. The clinician might drift into the police role. So it was really important to identify these are your areas of responsibility, and this is where you stay and your focus remains. Setting boundaries and preventing scope creep of the CRT unit. People, even the police department would get very excited and would begin calling the unit for situations that were not appropriate for them. I'm thinking of some hostage negotiation pieces. That's not what CRT should be doing. Again, we're targeting the low-lying 911 calls. So when I saw my team on a building getting in harnesses to de-escalate a suicidal client, I was very grateful they were there, but perhaps that is not where that was intended for. So really setting, these are the calls that are within our scope. What are the calls that are outside of our scope? Making sure that we are aligning funding sources. We're split funding. The police department provides their 3, soon to be 4 officers in kind. The fire department receives funding from the Colorado Crisis System, and the Community Mental Health Center and our clinicians receive funding from the BHCON response program. The other piece that we really had to pay attention to is how to ensure quality service delivery. Sometimes you need to go slow to go fast. And so the team could get very pressured to feel like they need to go on to the next call, but making sure that you are fully resolving and connecting with resources for the call that you are on before moving on to that next one. Next slide, please. Something that became very clear very soon is that mental health providers responding or being available for the police, for individuals, is incredibly beneficial. And so we really wanted to figure out, how do we connect this with areas that maybe their calls aren't as high, but still provide them that support. And I'm thinking too of some of the rural areas. And so we've looked at paired virtual response. How can we expand this, and also how can we manage the cost when this might not be okay to support a full-time clinician, but how do we still provide them with that support? And so we've really looked at maximizing technology and virtual support. This has been awesome because there's no wait for travel time. They're not on, the officer isn't on scene and having to wait for a clinician to arrive. We are able to do this almost immediately through tablets. We use Microsoft Teams as our virtual platform, where the clinician is able to assess and meet with that individual and quickly determine, what is this going to look like? Is transport recommended? Am I able to say, you know what, police, we can go ahead and release you, and I'm going to continue to work with this individual via their own device? Or are we looking at another level of care? This has really helped, as many of these cases can be resolved on scene, whereas before they were having the need to transport them to the emergency department. So this allows a quicker return to service. Some barriers we ran into this that we've had to problem solve is technology limits, right? Sometimes the rural locations don't have the greatest internet connection. And how can we support them if transportation is needed? Do we meet in the middle? What does that look like to help facilitate that quick return? Next slide, please. I just highlighted some areas of where the community response team CRT has been highlighted in the news, either through our local Colorado Springs or Denver location. Next slide, please. And just an overview again of what made CRT possible. And a huge part of this was partnerships, was forming partnerships and talking and willing to extend outside of how we have normally operated, and willing to do things differently. Next slide, please. And just in closing, this was just some feedback that we received from PD, FD, and also one of our local medical hospitals, just about the changes they have been seeing, the reduction of individuals being brought to the emergency department, and how that had been helping their organizations, which was one of our goals. So being able to see that reflected back within 1 year was incredibly heartening. Next slide. So I will close with that, and just hopefully that gave you an overview of some of the challenges we faced, the thought process we had to go through, and the community stakeholders that we had to pull in, as well as the results that we are seeing. So thank you so much for taking the time to listen to me.
Hello, everyone. My name is Lauren Hubbard, and I am presenting today on behalf of Milwaukee County's Behavioral Health Division. I am the Director of Community Crisis Services at Milwaukee County. Next slide, please. Today I will be presenting to you all about our version in Milwaukee County of our Crisis Assessment Response Team, which we refer to as CART. Milwaukee County has been the leader of our CART team in our area for the last 7 years. Next slide, please. So I'm going to take a step back and just give you all a picture of the agency that our CART team lies within. Milwaukee County's BHDR, Behavioral Health Division, is a part of our county's Department of Health and Human Service agency. And we're responsible for providing services to individuals with both behavioral health and substance use challenges within our county. The Behavioral Health Division is composed not only of a crisis service, again, that responds to individuals with immediate needs in the community, But we also have a inpatient hospital, outpatient-based services, and a psychiatric crisis emergency room as a part of our larger continuum of care. The services that I happen to oversee are more community-based crisis services. We do operate, like many other counties, a crisis mobile team that operates from our county's crisis emergency rules and standards. That crisis mobile team has a 24/7 crisis line, and we also are a call center for the National Suicide Prevention Lifeline. Again, those calls often result in face-to-face responses in the community, and we're able to do so from 7:30 in the morning until midnight at this time. There's a large response needed in our county. We have just over 950,000 residents in Milwaukee County. Recognizing that there are several specialty populations, a CART team is one of our specialty teams that branches off of this mobile team. We also have briefly a community consultation team that services adults with intellectual disability challenges and mental health in the community. We also have a geriatric nurse who operates for those ages 55 or older. Again, we do still serve individuals 17 and under through our Children's Mobile Crisis Team, and a subset of them, which is a trauma response team that responds uniquely to people that police or law enforcement have encountered during other traumatic situations, burglaries, arrests, domestic violence situations, and receive referrals directly to that team to follow up with ongoing care and services for you. We also have within our small crisis service a crisis case management team that helps individuals in the community for up to 6 months. Short-term services are linking them up to other long-term services and helping them to bridge that gap in between. Our community linkage and stabilization program receives lots of referrals internally. It is a certified peer program in which individuals with lived experience are able to help those that we service into recovery. And then we also have several crisis stabilization homes or community resource centers that, again, all of these teams refer to and also help support individuals within the other sister services. Next slide, please. So Milwaukee County's CART team. Our first CART team or first unit was initiated in 2013 in collaboration with the Milwaukee Police Department. The city of Milwaukee is our largest city within Milwaukee County. Within our area of the country, we mirrored our CART team off of Houston's police department, their CERT team, which just like theirs is a co-responder program. Again, like many other of the presenters before me, our officers are dedicated officers to our CART team. They're CIT trained, and we pair them with master's level licensed clinicians. These clinicians are all originally part of our crisis mobile team and then have branched off into this specialty higher acuity service. Just like the objectives of the CERT team, we are assisting officers with CIT related calls, conducting proactive follow-up for any CIT related investigations or service calls that we may go on, and helping to assist in certain low-level SWAT type calls or emergencies in which law enforcement officers could utilize the assistance of these specialty officers and clinicians. Next slide, please. So the objectives for our CART team were to decrease the volume of involuntary emergency detentions or having people's civil liberties suspended to get involuntary mental health treatment. We wanted to reduce those emergency detentions in Milwaukee County by being able to offer more voluntary options to stabilize individuals on scene to help keep them in the community versus being hospitalized or jailed, and to provide referrals to other appropriate mental health services. Another objective was to provide mobile mental health assessments, not only for community members, but also for criminal justice facility clearances for those that may be in custody. We also wanted to respond as a resource to squads with high priority crisis calls, those that had persons with mental illness, those who are suicidal, such as barricaded subjects, people threatening to jump off of a bridge, or assessments with other active psychosis symptoms present. Our CART officers and clinicians are only called in once the scene has been secured and once we actually have the capacity to be able to intervene and interact with the individual. And again, as I said before, to divert individuals in crisis from hospitalization or jail as appropriate. Next slide, please. Continued objectives to decrease the possibility of the use of force and injury to officers, to consumers, and to community members. Just by recognizing having specialty trained individuals who are great at de-escalation and who try other alternatives versus use of force, which could be the case when law enforcement arrives on scene. Another objective is to attempt to decrease the number of repeated incarcerations, as discussed earlier, for individuals who have persistent and serious mental illness that may be going back and forth between the behavioral health system and law enforcement systems. Next slide, please. So Milwaukee County's CART team, originally we partnered again with the Milwaukee Police Department and then expanded in 2018 to also service the city of West Dallas. West Dallas would be our second highest utilizer of emergency services within Milwaukee County. So that was a great next partner. For both of these collaborations, the Behavioral Health Division did fund for the first 2 years, not only the clinician, but also the officer. And this initial funding to start up was really just to show the dedication to our partners that we were really committed to this co-responder model, and also that we really believed in the positive outcomes that we knew it would yield. Again, we have dedicated officers for each team. Their primary objective is responding to calls either that are dispatched by 911 or by non-emergency. Also, other officers call for collaboration or for response to a scene if once they've arrived, they've noticed that there's a behavioral health concern that CART could be assistive in helping with. We arrive to stabilize individuals in their own natural communities, their own natural environments with their supports and natural resources. And then again, we link up to other voluntary treatment options, community-based options, and ongoing support systems. The goal of decreasing those emergency detentions is to help identify appropriate alternatives for people that will make a positive impact as they're experiencing crises. Next slide, please. So by being able to partner with our law enforcement partners, our team is still able to ensure safety and initiate that the proper response is there. In the state of Wisconsin, involuntary mental health holds can only be initiated by law enforcement officers. So this co-responder team really does allow us the ability to be able to detain people if necessary, but work really, really hard towards being able to keep them in the community. Our team is also available to assist with other encounters by police. They help intervene, secure assistance, and can sometimes take over scenes depending on what the event may have been in our community. Unfortunately, several events have occurred in the last couple of years in which our CART team's assistance on scene has really been helpful to provide mental health first aid, not only to other mental health professionals, but law enforcement officers that are involved in some pretty risky situations. In Milwaukee County, our CART service is available currently 7 days a week within the city of Milwaukee. We operate from 8 a.m. until midnight at this time with one team that operates a first, mid, and second shift. We also operate 5 days a week in the city of West Dallas from 11 a.m. to 7 p.m. And again, as other presenters have shared, all of those service hours are really driven by the data. When our calls for service are coming in, when our psychiatric emergency room is experiencing their highest volume times that we can work to impact, and the same with law enforcement trends for calls for service as well. In 2019, our CART team made 2,820 community contacts for assessment, and that is with all of our teams combined. Next slide, please. In 2017, in partnership with the MacArthur Criminal Justice Foundation, we introduced a collaboration with the Milwaukee County District Attorney to create a DA CART team. This team was specific to assisting individuals who may be able to be diverted out of the criminal justice system, different types of deferred justice programs, and it also offered us the opportunity to have more jurisdiction than just the city of Milwaukee and city of West Dallas. In 2018, about 6 months into the West Dallas division of CART, we were able to expand into doing a youth expansion pilot. So traditionally, our adult crisis mobile services do service individuals 18 and older. But West Dallas has such a high volume that we took the opportunity to work in higher collaboration with our youth outpatient services to be able to respond to people, to link them up to services specifically for youth, and also to be able to provide comprehensive services for family. So we are looking forward to finishing up that pilot. It's gone on a little long at this time, but there's just lots of different opportunities, especially with COVID and the different changes with school closures that are changing the way that this initiative is, the direction that it's headed. And in this year, the Milwaukee County Sheriff's Office has also agreed to participate in this collaboration. So by the end of this year, the Milwaukee County Sheriff's Office will provide funding for 3 dedicated sheriff's deputies. Milwaukee County Behavioral Health Division will also provide the 3 corresponding clinicians, and we will be able to expand exponentially throughout the county. This county expansion will also provide us with the opportunity to work in different ways with our emergency management system and other 911 systems that we have had a little bit of trouble integrating with in the past. Next slide, please. And that concludes my presentation. Thank you.
Thank you all for your time and for your presentation and for this information that you've shared. It's been wonderful to see all of the work that you've put into it and to see the fruit of what has been going on for quite a number of years in your communities. We have a couple of questions. Our first question, Carrie, is for you. So you mentioned that you had about 300 calls and that you were able to respond to about 100 of them. What happens to the other 200 to 300 crisis calls?
So our general patrol deputies are responding. They may or may not be CIT trained, depending on where the call happens and what district that they are positioned in, but our patrol deputies will respond and determine whether that person needs appropriate services, and they will take the person on an M1 hold. All of our patrol deputies use the Columbia scale as well to determine whether a mental health hold is appropriate. And then if they feel that that person would benefit from further services, then they will refer that person to our case manager, who can then follow up with them after the crisis.
Great, thank you. Do any of you want to follow up in terms of how you manage overflow of calls to your systems?
I can chime in from Milwaukee. Similarly, it depends on how the call will come in. If it's a call that's dispatched through 911 or non-emergency, another CIT trained officer would respond versus a CART team if they're not available. Aside from that, calls that may come into our general crisis mobile team can initiate the same response. It would just be a matter of waiting for the clinician to arrive to be able to provide that co-response in mental health.
Thank you. Another question that came in is if you're familiar with Parent Peer Specialists program, how do you see that fitting in with helping family or parents in an emergency situation involving a child at home, or if you have adult or a minor in the home?
I am not familiar with that program. I can speak to response and paired response. There is a lot of recommendations and research towards involving peers in that process, but I'm not familiar with that specific program.
In Milwaukee County, we do incorporate certified peers within our larger crisis service. At this time, we don't necessarily involve them on scene, but once the scene has been stabilized, once the crisis in that moment has been destabilized for safety, there are often times where our teams will contact case management services, personal supports, professional supports, which could very well include parent peers, or for the adult population, peers, to be able to either respond in the moment to help collaborate as like a crisis staffing, or if we can, within the next 24 to 48 hours, schedule a follow-up staffing for all parties that are important to that person and important to their treatment. We will definitely collaborate with them if they're available. And if not, then we work to link them up with those individuals if they see that service being appropriate for them.
Yes, Wisconsin has a parent certified peer specialist program where parents can be certified by the state to be in caregiving roles within the response system. So that is something that is being incorporated around the programs. But it is a great question in terms of seeing how they can be incorporated into on-site crisis response. in terms of how the programs began, how were you able to incorporate stakeholders? So, Emily, I'm wondering if you can talk about sort of how this came to the state and then how it went down to counties, if you could take us back to those early years.
So the program, the Office of Behavioral Health has been funding these programs since right around 2016. We started kind of dabbling in it, and then in 2017 there was legislation to dedicate funding towards this. Most of the funding comes from Marijuana Tax Cash Fund, which is why we have so much money that some other states don't. And the irony is not lost on any of us that that's how this is funded. And the legislation was originally really looking at our crisis system. We do have a statewide crisis system that includes mobile crisis, walk-in clinics or centers, and crisis stabilization units, but they were seeing that there was still a gap in helping first responders respond and take some of the pressure off of first responders and put it onto the behavioral health system. And so as part of that legislation, it really focused on trying to bring the behavioral health system and law enforcement and first responders together. And so this notion of and the need of collaboration and partnership was built into the program. So within our contracts with the different programs throughout the state, they have to have a steering committee. They have to bring people to the table because we know that's what works. And so that is one piece that is built into it, and it is I think the success rate varies, but I think after a while of kind of being forced together, it kind of makes or breaks the program. And the programs that do have those strong community collaborations and come together are the ones that are able to successfully provide the services and keep the teams going. Did I answer your question? I don't know if I did.
Yeah, I think what I heard you say is some of it was at state legislation level with some laws that are not yet in place in Wisconsin in terms of substance use funds and marijuana money, in terms of establishing money for that. And I know others of you have talked about not relying on grant funding, but instead incorporating it into budgets. And then what I heard you also say is that a lot of the success of the program really works on sort of what Erin was talking about in terms of everyone working together, everyone being in a van together in whatever version of the van that is, whether that's cubicles or conference rooms or actual unmarked vehicles. We have a question about how to begin. And I'm wondering, Lauren, could you talk a little bit about who were the first people that needed to be in the room to, someone has the idea, who do they go to next to get this program started?
Yeah, so the initiation of our CART team was a tad before my time, but I do know that within Milwaukee County, and again, as we spoke about in the state of Wisconsin, emergency detentions are initiated by law enforcement officers. And just so looking at the data and recognizing how often law enforcement officers who may not have been CIT trained at that point or hadn't yet had the experience or the desire or the skills, whatever it may have been, to respond appropriately in some situations, our residents were being emergently detained often. And so as a behavioral health division, how do you impact that? How do you help to decrease people's civil liberties being suspended for a moment? How do you help get access to resources in the community? And also access to resources for law enforcement. And how do we help bridge that gap? So not only was it leaders from Milwaukee County's crisis service who's overseeing our psych ER, who's sending out mobile teams to other emergency rooms to do assessments on people who have been detained. It also really took, for us, the largest city is the city of Milwaukee. So it really did take having someone at a high level at the table who was able to recognize the benefit as well. So our CART team, it is a resource for the county, but it was primarily started as a resource for law enforcement. how can we provide clinicians to you all to help impact this part of your service that maybe could be done in a more public service, trauma-informed, culturally diverse type of way that is a lot more of our specialty than it is for you all. So again, for us in our area, it was the behavioral health division, trying to help decrease that, trying to help provide more humane responses to emergency situations, and then really providing that resource and getting law enforcement agencies at the table, first being the city of Milwaukee and now West Dallas as well, to recognize that their law enforcement teams could really use this service, and then we could provide that opportunity for their other officers to be back on the street and dealing with other higher acuity situations that may not be behavioral health based. And the second thing that I'll say is the county being able to fund the officers for the first 2 years really showed that commitment. And so if there were stakeholders that were skeptical or ambivalent at first, us being able to put that funding towards it and then immediately see the outcomes, the decrease of emergency detentions. We're at an 80% diversion rate versus before it was an 80% emergency detention rate. So those impacts were really able to show our stakeholders after the first couple of years how impactful this resource was for them.
Erin, can you talk a little bit about who needed to be at the table as you were deciding how to bring, like, how is it decided that it would be FD, EMC, et cetera?
Yeah, it began with it began with the defining of the problem, but then who was seeing that could have the most benefit from the system changing. And so that very quickly became, okay, that is the fire department, the police department, also the emergency room departments, and the community mental health centers. That is how it began, as kind of what are the 4 agencies that we need to begin to work with, and then what shared or mutual benefit can we even see from this. For the fire department, it was always very clear to them because they are usually the first to respond for these type of calls. For the police department, it did take a little bit more for them to be willing to give us the support for that resource of taking a body off of the patrol. And so it really began with talking about, this is the change we could see. This is the benefit that could be seen for you, and then bringing that up on through the chains. Once we got agreement from those core agencies, we were then able to look at, okay, how can we help the emergency departments and help do direct placements? How do we bring our psychiatric facilities to allow off the street placements? Because it makes it much more difficult if they say, nope, you got to go to the emergency department. We've already then missed the chance to help reduce that impact. And so that became the next piece of look at the benefit for you in patient facilities. If you can get direct referrals and more referrals, that you're on the top of our list, and the community benefit that you are supporting. So it became both about the share about what is the benefit for that individual agency, and then what is the global larger benefit of the community that you can help be a part of. I hope that answered what you were asking.
Yeah, I think identifying who the stakeholders and who had buy-in into those direct results.
Yep, who was being impacted by our system being misaligned. Mm-hmm. And it was an obvious piece too was the citizens, but more than that, what are the agencies that are being impacted by our system not being aligned as it should be?
Yeah, thank you. I have a question. We have a question here is, when assisting emergency room diversions and doing direct placement into inpatient units, did you have to work with your local inpatient units to change their medical clearance processes? Our local units here in Wisconsin usually request blood work and other labs that would be difficult for a mobile unit to complete. How is that addressed? And for those of you that do direct placements, do you have complete medical clearance at a local ER?
I can start with that. We originally that's what I refer to when it's the iStat. It's this mobile lab machine that's able to take like a drop of blood and get the whole printout of the various labs. And that, as we began, was our in between of, hey, take these direct placement, but the medic can do these labs for you. to ensure that we're appropriately placing individuals or not giving you someone who's medically compromised that perhaps needs emergency medical treatment. Trust us with this protocol. As we've gained traction with them and as we've begun to say, hey, this is okay, they have actually reduce the reliance on those labs and are just going with our initial screening of the vitals, the tox screen, those pieces, because that can be a barrier for direct placements is having to stop everything for that full set of medical clearance. And it wasn't so much having them change their protocols, but be aware of the limitations that we're working with while being out in the field and what are they willing to compromise on for these unique situations.
I can add to that too for our team because we don't have a medic. It's just a clinician and our deputy. I actually did go and meet with the psych hospitals, and Erin has an inpatient unit as well. So we discussed this as well. And they did not change their requirements, but they were willing to pilot with us to allow at least our specific team to call in and do a kind of nurse to nurse discussion and give self-report from the patient, observations from the clinician, and then the psych hospital did have the right to still refuse a direct admit, or they could take our word and then allow us to bring the client for a direct admit. And then the agreement was that if they got the client and then they did have to send that person out to the emergency department because there was some unforeseen medical issue, they would let us know. So that could inform our practices for next time we had somebody in a similar situation. So if anybody else from our office, a deputy, tries to do a direct admit, they would be required to do a medical clearance at the hospital. Our team is allowed to bring them under this special circumstance.
And something that was really helpful in allowing that to continue and paving the groundwork was that monthly meeting of saying like, hey, you guys brought us this person, what is going on? Or everything is looking great. But that also helped to build the relationships and the trust with the screening and observation protocol.
Can you talk about the follow-up services that you provide? There's a comment about the challenges that people are in the system, maybe the loyal customers that were referred to, or I think, Lauren, you guys also do follow-up. What kind of supports are connected to follow-up, particularly for people who are kind of regulars in the system?
So for us, it is first to start with the case. Well, if they're not already connected with our system, it'll be, connection with the case manager. Pre-COVID, it was a little bit easier where it would not only be via phone, but it also would be community-based. So we would let them know, hey, they may be trying to come in to drop in on you, because a lot of times these are the individuals that might be hard to engage in the traditional mental health system. So really trying to engage them with where they are at to then bring them into, is it just case management you need? Do you need med management? Do you need individual group therapy? What does that look like to help so we can direct you to the appropriate resources so you don't feel like you're in crisis and have to call 911 all the time. So, but it was both a mixture of community-based and traditional methods of outreaching.
I will echo that for Milwaukee County. Our CART teams and all of our mobile teams provide short-term follow-up with all individuals that they serve. So if we have a phone contact or we go out and have a face-to-face, right now we are still mobile and providing appropriate masking to our clients as well. We will provide phone follow-up and face-to-face follow-up if the situation warrants it for 2 to 3 weeks. Being again a larger part of a larger crisis system, we are able to refer to short-term case management or long-term services. We have our peer-based crisis service that we allow individuals that our crisis teams work with to get direct referrals into as well. So it all depends on what the individual needs, but we have the ability to make those direct referrals as a part of our larger system. Like Erin said, if they aren't already connected, if they are connected, to re-engage them with those supports, and we can help carry them or follow up with them in the meantime until those supports are either initiated or picked back up.
Thank you. Just a last question.
One more unique thing that we do for loyal clients. We learned this from Houston, because we also went and checked out Houston when we were developing our program. And we create response plans for our general patrol deputies. And so we have an online system. So like if there's a person that calls 911 frequently and it is because of a behavioral health issue, we'll put a caution on their address that lets the responding deputy know that there is a response plan for them available, and they'll get into our system then and look at what's worked, what hasn't worked, some recommendations from our team, because we're not always on, right? And so somebody else is going to have to respond. So we make that available for them so that hopefully they'll have a better interaction with those people.
Thank you. I have one final question. If we could quickly just answer, what is the next step looking at the data, or what is the next area of growth, or what is the next goal that you've identified in terms of providing services? Whether it's increasing, adding a unit, expanding to another county, what's next?
For me, and it is really focusing on leveraging technology to provide support when the unit can't be there, and hours when it's after. I'm thinking of 2 of the after 12 a.m. hours. What do individuals do for when the unit is already busy, when the unit-to-unit call is coming in? So how can we maximize the resources we have for the other officers, responding officers?
For us in Douglas County, it's started to become a focus on youth. We were showing in our data for 2018 and on trend in 2019, around 37 to 38% of all the contacts for CRT, all the referrals were for individuals 17 and younger. So we developed a youth response team. And so I see kind of developing that relationship with the school, continuing to refine what that response looks like for youth in particular is really important. And the other thing we're working on is like the next sphere ring around the CRTs. So once someone is moved out of crisis, but perhaps there's still severe and persistent mental illness or substance use occurring, we've started to partner with all of the major providers in the area who do mental health, substance use, intellectual and developmental disabilities, safety net services, to provide a ring of case management, intensive case management support around those clients.
In Milwaukee County, it's a couple of things. The entire county, not just the Behavioral Health Division, is in the midst of a crisis redesign right now. So again, behavioral health, law enforcement, private health systems, we are all really working towards working better to collaborate, working better to have no wrong door for individuals wherever they might show up within the system. So for our CART team specifically and mobile teams at larger, we're really looking for better integration. I've heard really great examples today about how paramedics and fire work a lot more collaboratively with the CART team. So that is something that's on our agenda for the next year or two, including youth integration. Looking forward to having that as a possibility with our county CART teams that will be able to go all over the county for appropriate response. And then as well, working to over time being a lot more proactive instead of responsive to crisis situations, as we have better relationships and are better able to collaborate with our community stakeholders. As that grows and expands, we look forward to being a lot more proactive, doing outreach, continued education and training, involving ourselves in lots of different areas where we may not have traditionally been the public response. I think this time and the 2 different pandemics that our area is really suffering from right now gives us the opportunity and ears that we haven't traditionally had in the past.
Thank you so much, everyone, for your time and for your presentation. If you could take a moment to fill out the evaluation that will come up as you exit the webinar. Also want to invite you all to the NAMI virtual event on September 29th, and you can see that on our website. And Lauren will actually be presenting more in depth about the CART model. So if you're interested in more information about the CART model in Milwaukee, that presentation will be happening at the NAMI Wisconsin virtual event. And please do visit us on Facebook and like our page. So thank you all very much for your time.